Next speaker, Jenny Albertson, is amazing. You can read her bio in the conference program. You have the QR code on your table, or you can go online to the conference program page. And one of the sentences on her bio that I just think really encompasses a lot of what I know about Jenny. She is an expert in state and federal regulatory requirements and believes innovation is still possible to make the receivers of care the drivers of all we provide. Please welcome Jenny Albertson.
They tried to make this easy on me with red and green. Here we go. So the conference topic, I don't know if all y'all looked at this when you registered, is really the foundation of where we have to start. And you at the risk of sounding like I was trained in the School of Redundancy, you're going to hear some themes that you've already heard all morning that tie into that topic because it is foundational to how we move forward. I'm going to start by giving you a lay of the land. And I do this every year for those of you who have been here before, but the lay of the land this year is particularly driven by our awareness of demographics. If you look at the Bureau of Labor and Statistics United States Census numbers, that does not look promising for workforce development as much as it does for geriatric care moving into 2060. The comparison of our elder population growth to our workforce base is now going to be very disproportionate in Colorado. The lower graph shows you the ratio shrinking. I wanted to throw in this other quote from the Common Sense Institute about housing to show you how cyclical and how interdependent our age groups are. I think we all feel it when we shop for a home, that the elders that are hanging on to their life in their home and resisting coming into our care are hanging on to housing that is desperately needed and deterring people moving in to the workforce in Colorado. So this is a mutually reinforcing issue. There's also another prong to what we are experiencing in our profession, and that is that there is a decrease in faith and investment in science and healthcare. You may say, but what about the MAHA movement? Of course there's a lot of belief in healthcare. Well, you may have noticed there's a bit of a discrediting of the institution of healthcare and science in the process of the MAHA movement. So you're noticing things like, for example, a termination of $250 million in ongoing and planned federal funding for public and behavioral health care, specifically in our state. You will also notice that the National Science Foundation and EPA is going to be cut by 50% in the 2027 federal budget. This is not going to go away. It's an ongoing issue, and we are going to continue to feel the squeeze in reimbursement. The result of this in Colorado, among many other things, is a reduction in Medicaid reimbursement of 2% across the board for all Medicaid programs in this coming fiscal year, beginning in July. Our state is now 42nd in the nation for federal investments received. There's a lot of reasons for that I'm not going to go into. I think you can read the news. So the state of the economy does have an impact on our continuum of care. Our families definitely delay moving their loved ones into higher levels of care because it's costly. They also don't want to have to spend down resources and qualify for Medicaid. Residents, particularly in assisted living, try to stay in their homes longer and move with more advanced care needs by the time they get to us. So what we're experiencing is a direct correlation in acuity increase. And then, of course, we have increased homelessness, particularly exacerbated in the economic pinch of COVID. And that lack of family or dependents that can follow them in the community prior to coming to us also increases their acuity and their lack of care that they've received along the way. Economic disparity is also growing. You may have noticed that there's like 1% of our population that seems to not be paying taxes. We are now less able as caregivers in our communities for our loved ones to provide the care that they need at home because we all have to make a living. We can't stay home and care for our family members like we may have done back in the 40s, 50s, 60s. And I want to note something that already was mentioned by Carrie earlier, and that is that we have a particularly interesting segment of the care continuum in that we're an understudied population. Research on geriatric health is disproportionately lower than the proportion of the population 65 plus, even though that's the age group that has the higher burden of chronic disease, and we should therefore be focusing our knowledge in that way to cut cost, right? And then Colorado specifically faces a significant shortage of geriatric specialists. You're seeing a very valuable resource in this room. Why do I note this? Because it's all part of the bigger picture that we face when we are trying to envision a future of leadership in long-term care. We know elder care more than anybody else. This specialist group in this room, ranging from surveyors to clinicians to pharmacists, we're operators. We have a custodial community living model that is unique in the continuum. By the way, it is the least costly part of the continuum in terms of growth for Medicaid expenditure across the state. Our billing for patient bed days has gone down over the last 10 years, and we're the only part of the Medicaid payment system that can claim that. We offer a non-curative disease management model. You heard about it with Leslie. We have those difficult conversations where we truly could say we can't do anything for you, but we can do a lot for you. Our care model is care over the whole person, preserving dignity, with clinical specialization that comes from a lot of years of lived experience in this room. We have compassion that others can only kind of dream about, I think, in other parts of the continuum because they don't have the time to spend getting to know their folks. So we, collectively in this room, would have a vision then for the future, which is us together standing in that gap for these folks that do not have the focus of the rest of our society. What do? We advocate, we make the most of what we do have, we keep our focus, and we tighten our connections. So let me elaborate on that a little bit. First off, advocacy. You know, my role is to meet with legislators and whatnot part of the time. You all do not experience that. But what you do experience is a constant verbalization and demonstration in what you do of the care that we provide and the care need that we serve. So I want us to project transparency in that. What am I talking about? You might require, as an operator, staff to experience life as a resident in their first 3 months on the job, one overnight in the building. There are buildings that are doing that. You might say facilities would host block parties for their surrounding neighbors. You might see that dementia caregiver support groups are being held in nursing care facilities to support communities, even beyond the caregivers that are represented by their residents. Volunteer programs that make even our unfriended residents feel like they have somebody who's not a staff person that they can count on. Inviting local churches to learn how to be guardians and conservators in classes that we might provide in our facilities. For too long, nursing homes have been running scared from lawsuits or angry, grieving families. But in truth, we have nothing to hide. We can be open, we can be educators, and we can be honest. And this is advocacy. When we fail to share the joy we have in our work, the value we see in a person who is very different from who their old self represented, we rob the public of understanding a very significant part of our society, our elders. We have a unique window on what so much of the people around us are afraid of. Have you noticed how often dementia is mentioned and dementia prevention in your media feeds, or how often mental health talk is seeping into your everyday conversations? People need to know how it really is. You're witnessing it. They aren't. It's a growing need for our elders, it's a growing population, and it's all of our responsibility as a society to keep caring for these folks through the changes of minds. So what can we maximize that's already out there? If the reimbursement is shrinking, the picture is not pretty, and I'm not here to lie to you. We have to staff for economies of scale. You are one medical director. You may have a few providers that support the care that you provide in your community. You cannot duplicate yourself. We will have more elders needing care. We will have to spread some cost through volume. There are payment structures that are built to support this. In the state of Colorado, we have a couple of very wonderful programs, one of which is a supplemental payment for high Medicaid population, the very people that need our care more because they cannot afford anything Cadillac level. We can provide them Cadillac level under Medicaid reimbursement and get an additional reimbursement for having an 80% or greater threshold of occupancy in Medicaid. We also have a pay-for-performance program in the state of Colorado that incentivizes quality achievement and invention in achieving that quality. We cannot simply make people expand, right? When you make efficiency your primary goal, you lose relationship. And I'm here to tell you that relationship, whether it's between us, like Joe talked about, or relationship from a resident to their person they're caring for, it matters more critically than anything else we can determine for operational expenditure. The relationship building can be the foundation for achieving a higher level of quality. Our residents can do more also. You heard that from Jennifer. I told you, redundancy, redundancy. Our residents can do more, they can be more, and they can experience more in their communities if we are inventive, and so can our staff. And who wants to work in a place where life is not actually worth living, it's just simply living? Do we ask our staff what the resident did independently or what's declining? Do we encourage the nurses to chart an elder's motivations or desires so we actually know how to motivate them? Where can we cut paperwork? We have to ask that question. How can the residents help in the day-to-day of their own communities and take some leadership themselves and regain some sense of meaning? And when was the last time a CNA led a quality improvement project in a building? As much as we have to manage clinically, we have to make room for an improved quality of living to divert our focus to what really matters. So how does an elder feel when a caregiver is rushing from one person to the next and doesn't look them in the eye? We all know how it feels, because it happens to us when we go to see our doctors, perhaps. When COVID threatened our relational connections with our families, our internal social networks, our volunteers, we lost something very real. Suddenly we were the enemy. We heard it from CDPHE earlier this week. Complaints went up exponentially when COVID occurred, and they have not declined because suddenly the dynamic was switched. We were othered. We were the enforcers. We suffered moral injury in the process. And we know, especially now after experiencing that without a relationship, people will not tell you how they really feel. They will call the state instead. Staff will quit because they don't have someone they consider a friend or a loved one at work. This costs us nothing but an insistence on living our values. So let's tighten these connections between us in that spirit. Medical directors are essential to a skilled nursing facility's realization of quality. You know that. You know things we don't know. We know things that you don't know. We have to be interdependent. Increased acuity, litigious families, payment barriers. We've found our way through a lot of difficulties historically and continue to do so. And it makes it more and more apparent how interconnected we actually are. And we don't have room to bypass this opportunity to be connected. If a system issue is making your job harder, you detract from yourself and the care you provide by not bringing it to someone's attention for improvement. If a nurse doesn't do a dressing change correctly or provide a proper assessment, do you let it slide? We can't afford to tolerate that anymore. We, together, lead long-term care forward from a position of strength. We have an understanding of what's coming, a vision for how we can always pursue betterment, and a confidence in the need of our specialization and the need for it. Our fulcrum of shared values can be our pivot point to move forward in interconnectedness and relationship. Thank you.
Well, your leadership inspires me, Jenny. Thank you very much.